Good afternoon and welcome to the Primary Care Innovations webinar series supported by the James Free Center for Primary Care Education and Innovation. Thank you all for taking time out of your busy schedules to join us this afternoon for this webinar. The title of the webinar today is Meeting Patients and Families Where They Are, Implementing a Telehealth Strategy in a Healthcare Transition Clinic. Just a couple of housekeeping items before we get started today. First, make sure you've muted your microphone, which should have been automatically muted as you joined. And also, please turn off your video unless you'd like to be recorded for future replays of this program. We have these logged on our website and the Primary Care Innovations website, as well as the James Free Center website for future viewing. So you'll forever be a part of that. So feel free to turn off your video camera like not to be a part of that in the future. I'm excited to introduce our speakers today. We have a number of speakers from our University of Florida, Jacksonville, specifically with the Jax HATS program. So let me introduce our speakers. First, Tina Smith, who's a telehealth director for the University of Florida College of Medicine, Department of Pediatrics. She holds certifications as a certified telehealth liaison and certified telehealth coordinator. Tina's been with the Department of Pediatrics in this role for over 10 years, initially working with First Coast Child Protection Team's telehealth program. She's also a member of the University of Florida Jacksonville Telehealth Task Force Committee. Dr. Rita Nathawad is a medical director of the Jax HATS program. And the Jax HATS program is a medical home for young adults moving from pediatric to adult-based care. She's completed both pediatric residency and pediatric infectious disease fellowship training at SUNY Downstate Medical Center in Brooklyn, New York. Also joined by Chanda Jones as a case coordinator and certified community health worker. She's recently completed her Bachelor of Arts in Sociology with a concentration in social welfare at the University of Florida in Jacksonville. Chanda is part of the Jax HATS team and has been so for the last 6 years. And last but not least, joined by Lindsey Hollingsworth, who's a physician's assistant for Jacksonville Health and Transition Services, the Jax HATS program. She's worked with UF Health Outpatient Primary Care and completed the primary care program at Nova Southeastern University. We're lucky to have you all, and we'll turn over the program to you for this presentation. Thanks so much.
Thank you so much, Dr. Dahl, for having us. We're super excited to share with you our experiences working in this kind of arena. Just kind of as a disclaimer, so we use the term telehealth, but through the presentation we will probably use the term telehealth, telemedicine, and virtual visit interchangeably. The UF platform is called the virtual visit platform, so just for clarification in case anybody was curious about that. So today our objectives, first, we'd really like to be able to list the barriers to care faced by youth with special healthcare needs as they move from pediatric to adult-based care. And as you'll kind of see, there are some specific barriers and challenges where telehealth really lends itself to. And then we also want to then describe the ways in which telehealth can enhance the care of this special population, in particular in the context of transition. And then finally, identify innovative uses of telehealth that may go beyond medical management, again, in this population of youth with special healthcare needs. So just briefly, what I'd like to kind of start off by doing is giving you kind of a brief description of the Jax HATS program so you can kind of understand the context in which we're speaking about and a little bit about our population. So when we use the term young adults with special healthcare needs, that's sort of really an umbrella term and really constitutes any individual who has either an underlying chronic condition, may be medically complex, may have intellectual or developmental disability, other social or mental health conditions. So really any and everyone who doesn't kind of fall under the healthy adult category tend to get referred over to our program. We care for 16 to 26-year-olds, and we are a primary care medical home. We do a lot of work in care coordination, assisting with self-management support, education needs, social support needs, medical referral needs, and then specifically looking at transition needs that go beyond just referral to adult providers, but really looking at the non-medical issues that occur when you're moving from pediatric to adult-based care. And then just kind of to give you a little bit more of a framework of what we're sort of dealing with, this is kind of a mishmash of things that occur for our patients and why it's so hard when you're kind of in that transition time period of moving from being considered pediatric to adult. One of the big things going on in the upper corner, education. So a lot of our patients are in the process of graduating from their high school programs and then trying to figure out, do I need to find a job? Am I going to be going into some sort of vocational program, or do I have other needs that may be more looking at enhancing their activities of daily living? Transportation becomes a huge issue. So in the other corner, most of our patients are relying on the bus or JTA, public transportation, but in their heads, they sort of envision themselves with these fancy Teslas and cars. And so kind of navigating that, you know, there are some realistic barriers to transportation as you move into the adult world. Also, insurance. So what an individual is covered for as a child changes dramatically when you become an adult, and access to insurance itself also can change, in particular when we're thinking about Medicaid and Medicaid managed care. And so patients will often get denied insurance. They also, with their public benefit needs, there are also significant changes in terms of eligibility, so they can be denied in that area. And then just sort of this understanding of the differences between the pediatric world and the adult world. So that's kind of where that reception on the bottom corner, you know, I think our patients have this perception in the pediatric world that everything is very friendly and happy. And when they go to the adult world, while it still is very friendly and inviting, they have a lot of apprehension and concern, and they sort of see it as more, you know, there's a barrier there, and they're struggling with dealing with the differences in the two different environments. Next slide. So this is just our flyer. You know, we know that you can't read it. This is just sort of, we kind of started this program in Jack's Hats using the virtual visits about 1.5 years ago now. And so this is the flyer that we kind of give out to our families, and I'm gonna hand it over to Tina now to give you a little bit more detail about the actual virtual visits.
So the flyer also contains some directions for the patient on how, you know, what the requirements are for the visit. So they have to have a MyChart account. They have to have been seen within the last year, and it is BYOD, which is bring your own device for the patient. So they can use a phone, a PC, a laptop, or a tablet. So they can choose any of those devices. If they're on their phone or a tablet, we do use the MyChart app. And then if they're obviously on a computer, we use the browser. And what happens is once we schedule the appointment, we have a specific visit type for a telehealth visit. They will go into their MyChart and they will click on appointments, and they will see the virtual visit appointment there. So they'll see that they have a telemedicine visit. Again, we call it the UF Health virtual visit is the platform. And once they see the visit, they open it up and they see the begin visit. They click on the video and they are put into sort of a waiting virtual room till either our CSR or our physician arrives into the room as well. And then this from the provider side, the provider goes into their schedule. They'll also see the appointment. They'll see that the patient has arrived, and they have under their telemedicine tab to the left, they will see where they can click on the green link, and that will bring them into the room with the patient. And then they'll be able to move that screen. They're able to move that screen around however they want it. We always ask them to position it under where their camera is so that the patient feels like they're having the good eye contact with the physician and or the CSR. And now I'm going to hand it over to Lindsey.
All right, perfect. So thank you. This slide here shows a couple of different benefits and barriers that we've noticed among providers and patients. So a couple of the benefits we'll go over. We want to increase the access of care without limiting the quality of care provided. So another benefit, we can receive care in the privacy of their own home, so the patients are more comfortable. Also keeping their medical home intact, so not disrupting the patient's medical regimen. So patients that require feedings at certain times, all their equipment and formula is at home, so we're not interrupting that, which ultimately improves the patient and care team satisfaction. We also notice that it decreases barriers to care, such as reducing travel distance, the time, the availability, the caregivers, time off work, so all that is included. We've noticed a decrease in ER visits and hospital admissions since doing the telemedicine and making that available for some patients. It also gives them an option for care without or less expensive options. So doing a telemed versus going to the ER or an urgent care. Also improving health outcomes, and then a lot of times it's reassurance, decreasing no-show rates ultimately, and then increasing adherence to the patient's treatment plan. So a couple of barriers would be, as providers, we have a lack of physical contact for their physical exam. Vitals, we're not able to get vitals unless there's a home health nurse there, and that can verbally give that, or the parents or the caregiver team is able to provide that to us. Also, difficulties with technology, right? So we always have issues getting connected. So not only on our side as providers, but our patient side and the care team side. So we need to, they need to be comfortable with MyChart, the access, the platform of virtual visits, logging in, remembering their login, and so that can pose as a barrier as well. So also proxy. So if we have patients that are under 18, their parents are listed as the main, and then their proxy would be their child. So they have to go through their parents' email, and so sometimes we have patients that are more independent at 17. So that can pose as a barrier too for some patients as well. Next slide. So we're going to go over a few quick patient examples that showed. In each case, we're going to go over benefits and barriers that we've experienced throughout doing our telemedicine. So the first patient's a 24-year-old medically fragile nonverbal female with cerebral palsy, spastic quadriplegia, generalized convulsive epilepsy, and fully care dependent. So a couple of barriers we've noticed is that patient schedule, right, and their family care team. So this patient, in this case, mom had her own medical issues and concerns, and dad worked nights, so schedules were really hard, and so we were able to accommodate them and their family and able to get them at their whatever time worked best for them for their telemedicine. Also medical conditions. So with this patient in this case, it was like bringing the hospital room to the clinic. So there are a lot of she was G-tube dependent trach, she had events, so all that has to come, and we have to think about all that. And the travel distance is an issue as well. So patients with CP, 45-minute car rides will increase their spasticity and cause an increase of pain. So doing the telemedicine, the virtual visits actually, at home kept the patient comfortable, increased the patient's and care team satisfaction, as well as making sure that the patient was, comfortable. Next, actually, we're going to go over a couple of the benefits too. We talked about more frequent follow-up visits. We were able to do, weekly visits if we needed to, able to refill prescriptions faster, looking at their equipment in their home and seeing if that was, getting a good look at that and seeing if any of that needed to be addressed. Also med reconciliation. So this is something that they can visibly show us the bottle, show us what medications they're on and how frequently they're taking it. And then, ultimately this, increases adherence to medical care, improving access and quality of medicine while providing medical care. So the second example is a 24-year-old female with diabetes mellitus type 1 with an insulin pump, severe depression and anxiety, and significant social barriers. So this is a patient that was at risk of getting discharged from our clinic. She had missed multiple appointments, and we have our policy, or UF has a policy, after 3 no-show rates, you can be discharged. So she was probably at 10. And so this actually, virtual visits, being 24, this is something she was very comfortable with. This actually, re-engaged her with our clinic and was able to keep her from getting discharged. And so this patient, we looked at the no-show rate before telemedicine was 75% no-show. And after the telemedicine, it went down to like 45. So that was a really big improvement for her, medication or for her adherence as well. So another thing is this patient was, not well-controlled diabetic. So poor insulin or poor glucose control. So we were able to meet every Friday and go over her insulin log and journals and her food journals to have better adherence for her diabetes. So she also had several hospital admissions for DKA. And so doing the recurrent virtual visits and keeping a close, rein on her and checking her kept her out of the hospital and kept her from being admitted again for DKA. So basically improving patient compliance and coordination of care with endocrine too. So if there needed to be any adjustments, I would talk with endocrine and then follow up with her that following week. So another good thing with her was before we began the process of transition with this patient. So on her telemedicine, we were able to start that and then complete it because we transition around 25, 26. So this was a good example of beginning transition with her. Another barrier we saw with her was that transportation. So she relied on her mom for, transportation and coming here for the appointment. So doing telemedicine, she was able to do it at her own time, at her home, and didn't have to rely on her mom's schedule, basically. And then anxiety, depression, significant. This would all be decreased being at home and having telemedicine in her comfort of her own home. All right. The third patient is a 24-year-old male with autism spectrum disorder, significant behavioral challenges, severe intellectual and developmental disability, and fully care dependent. This patient is a example. For example, you would have behavioral outbursts in the waiting room. So we would have to frequently get him put back into a room. And then in the room with the provider, he would still have outbursts, didn't allow for a full physical exam. He would not allow for mom to ask questions. There was no opportunity because he was very disruptive. And so mom would have to, because of this, would have to hire additional help and pay out of pocket for someone to come take off their schedule, come and help. We would try to do our physical exam, and then mom would have the caregiver take the patient out. So mom and I can communicate and answer all the questions and go over the care. Well, that, as you know, would be very stressful to the patient and to the mom and to the caregiver. So doing the telemedicine actually allowed mom to stay at home with the patient. It was just less travel time, less stimulation for the patient, and a more problem focused. It would allow for her to ask her questions and give her an opportunity to communicate with us without the distraction of the behavior from her son. So those were a couple different benefits and barriers. Another thing, we have a video that we wanted to go over, or this patient's mom wanted to discuss how it was helpful with her.
Okay.
He would still come to the visits. I mean, we don't have a choice. He would have to come to the visits. It's just very hard on Dr. Nathawad and Dr. Lindsey for Stephen, because of his intense behavior. He doesn't like to be touched. He has sensory issues. From the nurse checking him in to try to get his blood pressure, to trying to get his temperature, his weight, he just excels. Virtual visit is better because we're able to achieve more with Stephen due to his challenging behaviors and meltdowns when we're there. I'm able to talk more with the doctor because I'm able to remove Stephen. He can go to his home, he can be removed from the situation. It just makes it so it's more consistent for Stephen with appointments and able to deal with the behaviors at home versus in a doctor's office. I always have to bring a one-on-one with me, and then my caregiver has to remove him from the situation, and that's hard for the doctor when he's not able to stay.
Okay.
I wish more Shan's doctors would do it, believe me, because we see a lot of doctors and I have brought it up. Stephen has chronic kidney disease, so we see the nephrologist. And we're also seeing 2 different departments in neurology as far as sleep and then whether he was having seizures. And I've explained to them that if we could do it at home from a virtual point, we could get more done with the appointment. Otherwise, he's in full behavior while we're there. They can do a simple examination on him without him getting very upset with them and having a meltdown. Versus at home, I'm able to get his blood pressure. I do his weight. I do everything beforehand. And all it really is asking questions, and it would just be more successful. I would get more benefit out of the appointments if it was at home versus there.
In regards to, I just find it kind of interesting. Do you feel like maybe some other providers do not realize the behavioral piece is so important in order for you to get the medical portion of it taken care of? Do you feel like it's known, but maybe it's not clicking with them how important that part is?
I very much so believe that.
Okay.
I mean, as far as I'm having to pay out of my own pocket, not that it shouldn't matter, but I'm having to pay a caregiver to come to these appointments because my husband works full time. I hire people to go to these appointments with me. I'm like, please, so you can take it. Otherwise, like I said, I won't get nothing out of the appointment with Stephen.
Right. And it does.
As you guys kind of saw, Lindsey kind of gave us a really good breakdown of some of the specific medical benefits with this patient population and using virtual visits. But what we also really do know is that it's not just about medical conditions and it's not just about the physiology. It really also tags into the social circumstance and how all of the non-medical things are playing in. And so what we're going to do next is talk about 2 cases. Chanda's going to kind of go over them, really talking about how some of the social barriers can also be overcome using the virtual visits.
Good afternoon, everyone. So the first patient, patient 4, is 24-year-old female with autism spectrum disorder, mild intellectual disability, anxiety, rheumatoid arthritis, relies on caregiver for shared decision-making and management of healthcare. So we'll once again continue to look at the barriers and then show the benefit of the virtual visit to assist with the barrier. So the first barrier is family structure change. And with this particular patient, the structure was changed drastically. The patient's mother, the primary caregiver, became unemployed, which also resulted in a decline in the mother's physical and emotional health. Another piece is mom became emotionally drained and realized she was unable to continue managing the patient's health care. So this led to the patient's aunt transitioning into this complex biopsychosocial role with minimum to no resources or healthcare background about her niece from the mother. So the benefit of the virtual visit was that it made the transitioning role for the aunt as the new caregiver less stressful. Another point is that the aunt was willing to utilize the virtual visit adverse to the other as coming in often. And actually this was able to de-stress the patient's psychosocial environment as well. And then lastly, the aunt saw the virtual visit as another way to meet the medical needs of the patient without breaking the care, if all at possible. The next barrier we were looking at is the loss of insurance coverage. And so the mother carried the patient on her private insurance plan, but once the mom was unemployed, the coverage was lost. And the family did try to apply for public benefits, but it was denied. And I want to say 2 to 3 times there was a denial. And that left the patient with no healthcare coverage or insurance coverage. So the benefit of the virtual visit again was that it was affordable. It was a practical means for the patient and the aunt to resume the patient's continuity of care in the interim of awaiting for some other type of healthcare coverage. The last portion or last barrier we were looking at was the intermittent healthcare access. And what happened was the patient missed several appointments due to the lack of healthcare coverage. Also, it decreased the access to healthcare because there was no insurance. And then we started to see it broke the stabilization of physical and the emotional health of the patient. So the benefit of the virtual visit was that the virtual visits was an innovative and effective way to address the healthcare dilemma of the limited to no healthcare services or insurance at the time. It encouraged the patient to take ownership of her own health along with being supported by her aunt. As well, it improved medication adherence, which actually was not happening as much until the change in caregivers and the virtual visits started. She felt a little bit more comfortable doing the virtual visits, and the medication reconciliation at home was kind of brought up more. And then lastly, it decreased the patient's anxiety about her missing her actual appointments. She really did have this desire to be when she could at the appointments, but it became a problem for her because she didn't know where she was going to get her care from. Next patient, please. Then our last patient, patient 5, he is a 22-year-old male with cerebral palsy, hypertension, mild cognitive impairment, wheelchair user who self-manages his medical condition. Again, we're looking at the barriers and then the benefit of the virtual visit. So the first barrier was technology apprehension. And with his age, we would all think, oh, they're all into this. No, he was not. So initially it was very uncomfortable, and there was technology leery, as well as noticing that there was some cultural miseducation about healthcare and technology. There was a decrease in that trust. As well, we'll look at the benefit. The benefit was that the patient was actually able to receive a guided tutorial and demonstration about the virtual visit from a familiar team member, and it heightened him to want to try. So it did, it helped decrease the technology anxiety, and once again, he was willing to buy in. Now we cannot stop him from using it. He is actually a super user of the virtual visit. So the next barrier we were looking at with him was he was hesitant in managing his health care. And he was actually, before even starting the virtual visits, the patient was adjusting to managing his health care on his own without his parental assistance, which he was very anxious and nervous about. With the virtual visit, it actually ultimately increases self-efficacy and skills and healthcare management. His healthcare managing comfort level increased. He began to schedule his own virtual visits, understanding the process of the clinic. He knew when it should be a virtual visit and when he needed to come in to see them in the office. The last point we wanted to look at was the frequent appointments. It was multiple appointments, and some of them was not all necessary for him to come physically into the office. So the way the virtual visits assisted was it was allowing flexibility of using the appointment for medication management and non-medical needs. It was able to capture medical and non-medical virtual visits as like a 2-for-1. Lindsey and myself actually last week I did something with this patient, and we just wanted to see if it would work. And so the provider is Lindsey. She started her session and discussed some things with him, and then I transitioned into the visit after she finished and gave him information about service dogs. So we were able to do what we needed to do in one shot. And so the outcome of this, especially with this particular patient, was he is the example of what the ultimate healthcare transition patient looks like at its best. This was an out-of-box and effective healthcare method, which is agreeable, especially for his generation, and it empowered him to function as a responsible young adult who is capable of managing his own healthcare decision. He is definitely a healthcare transition virtual superstar. Thank you very much.
So we kind of finished talking a little bit about our patients, and this is kind of one of our little jokey slides that we wanted to put in. So, telehealth dues, you want to definitely make sure that, Lindsey in this picture, the top picture being our provider, that you're aware of what's behind you, and that, you have kind of a good setting, and that is kind of more pleasant for the patient who Tina's acting as. Telehealth don't. So, I know we often, when we're on video, we're kind of like, yeah, okay, they can only see me from the waist up. So jokingly, don't wear your PJs and stand up. Don't, so just be aware when you are using virtual visits, that the patient can see everything around you. So just to be mindful of that. Next slide. I think we've kind of through this presentation been able to demonstrate, in particular with this population of young adults who have different categories of special needs and special healthcare needs and special social needs, that virtual visits really provide a much more robust platform for us to provide care in the context of all of the different things going on with our patients. And again, really thinking about those barriers that our patients and families find when they're trying to optimize their health and well-being. So some of the things that we've kind of started talking about in terms of future opportunities for using the virtual visit in our population, and I think just in general also to really think about is specialty consultations. So in this group, mental health access is very limited, and again, it's very hard sometimes for a patient. We've learned a lot about integrated mental health with primary care. It's much easier for a patient to receive their mental health services in the primary care office where they're comfortable, and so thinking about, we don't have that on site, but perhaps we could work with mental health providers who could then do virtual visits in our office with the patient when they're seeing us for primary care. The other thing is pharmacy. We have a lot of patients with very long medication lists, a lot of different potential interactions, things that need to be monitored. So we've also sort of thought about, could we, because we don't again have our PharmDs on site, could we potentially bring them in virtually to do those types of visits with our patients as well? So really kind of thinking about things outside of the box. How do we bring as much as we can to our clinic setting to really be comprehensive, because we know that it's very hard for our patients to go to new places, to have transportation to get to those places, and so trying to overcome those barriers. And then again, really not just thinking about the virtual visit in a medical context. As you guys saw, from a social perspective, there are a lot of things that we can also offer. We have a medical legal partnership. So again, being able to allow our attorney to engage with the patients when we put the referral in. We've talked about providing a platform where she could also do some virtual consultation, so that we don't have these large gaps in time from when we refer to her and the patient actually connects to that person. When we're thinking about transition, of course, we're really focusing on self-management skills, learning how to manage your condition, understanding your condition, learning skills for making appointments and talking to providers. So again, this is a platform that we could potentially use to do some of that counseling outside of a medical visit. And then again, even with, we work with a lot of community agencies. I always sort of joke around about this clinic not just being a medical home, but really a medical neighborhood, right? We are working very closely with a lot of agencies in the community, and is there a way for us to somehow bring them in virtually, so that, again, the patients can kind of have that feel and that connection before they have to go somewhere new. And then just thinking about research, I think when you look at the data and the literature on telehealth, there really aren't robust quality metrics that have been developed. So we don't really know how to evaluate this in a meaningful way to really look at outcomes. And so trying to think about that, and as we think about that, thinking about how we can integrate that into our electronic medical record system, so that it's not an extra thing that we need to collect, but how can we collect this in real time and be really explicit about it and focused. And then again, thinking about QI, quality improvement, and developing parameters and what does quality improvement look like for using a virtual visit platform. And then finally, survey development. So I think we do have some sort of general surveys that we use at UF Health, but I think maybe looking at some more targeted questioning, again, falling in line with the quality metrics, and then also looking for us specifically in our clinic in this population of young adults with special healthcare needs moving from pediatric to adult-based care, are there specific questions we should be asking this population, and developing surveys around that. And so that is really, go to the next slide. That's really it. We wanted to make sure that we really left a lot of time and opportunity for questions and discussion. So thank you so much again. We're super excited to share with you, and we'll open it up to any questions.
Wonderful. Thank you all so much. Really incredible work. Well, I forgot to mention at the beginning, feel free to, in the chat section, type your message, and you can send that our way. A few of the messages are the questions we have so far. So are there options that you all have developed for folks that don't have devices? I know it's bring your own device. Are there ways to get folks devices, or places where people can go maybe closer to home to access kind of like a portal to telemedicine?
We actually do have, so inside of our telehealth program here in Jacksonville, we also have a CDC grant that we've been working on. And within the CDC grant, we have put iPads and trained iPads at some of our family medicine locations, and some of our community partners. So if they do have the capability to get to one of those locations, we could have a visit at that location.
Great. Another question we have is, how do you orient patients and families to the use of the platform? Do that in person? I saw that there was a flyer initially. Can you kind of go through the orientation process?
So what we found to work best is yes, to kind of do the orientation process while they're here. And on the flyer, what we have on there is some direction on there on how they will perform the visit. But it is definitely recommended that if we can get the patient in the clinic and actually do a test visit with them while they're here on the device that they'll be utilizing, that definitely eliminates a lot of barriers on the back end.
And I'll also just chime in a bit. So because our virtual visit platform requires my chart, right? So you have to have access to the portal. What we have sort of tried to do in a very dedicated manner in our clinic is always look and see whether they're signed up. And then if they haven't signed up for my chart, have our medical assistant actually sit down and set that up with them in the clinic visit, so they've got that piece down. And then if we're talking about doing a virtual visit, kind of walk them through what that actually is, so that they're more comfortable. And then just actually yesterday, we had a patient that tried to do the virtual visit and ran into some issues, and then ended up scheduling an in-clinic visit, and Tina came up and then walked through it with her and did a test, so the next time we don't have that issue. Great.
A couple other kind of questions coming in. One is a big one I know that we're kind of considering here is the question of payment, billing, different insurance companies. What's been your experience in terms of payment as it comes for telehealth visits?
So we have a credentialing process for the providers and the MAs and the CSRs, and in that training we have a list of basically all of the insurance companies and who pays, what if there's a copay, what the copay is, and then we've been allotted through the chair of our department to, if they don't have insurance, then we have a standard price that we will charge for that visit. And then from the collection perspective, the CSR or the MA collects that on the front end when they arrive the patient, and they check the patient in virtually. They collect the payment up front. And then from a billing perspective, when we use the actual, that visit type that we're using flows to our billing folks on the back end so that they know, so that the correct modifiers are put onto that billing statement when it's submitted to the insurance companies.
Do you want to give the specific, like, so Medicaid, right?
Yeah, so we know that Medicaid, right? So I don't have them all in front of me, but Medicaid does pay.
I think that's the big one.
And that's, and they've been paying for a couple years now, but that is, and usually with the Medicaid, there is no copay. So we haven't really had any, we don't have that process with there. TRICARE is another one that pays regularly. And we do, for some of them, you can get a prior authorization from the insurance company for the visit.
Okay. A couple of the questions coming in. For folks that have maybe just more of a quick question, is there an opportunity to use this maybe with kind of telehealth visit with a nurse or RN, or are they primarily been used with a physician or PA, nurse practitioner? I know you mentioned some of that kind of pairing visits, but have they been used more, I guess, for more kind of quick questions, maybe to decide if a visit is actually needed?
Yeah, so actually this has been huge for us, again, being kind of a clinic that deals with a lot of patients with really complex medical needs. We found that we were spending a lot of time on the phone with patients, providing consultation and services, and not able to bill for any of that. So we actually have been able to now switch all of those to a virtual visit and then actually bill for that visit. So that's been one huge thing on the medical side. So when they call in for an urgent medical complaint, then we're able to kind of say, why don't we do a virtual visit and figure out what's going on? But we do, again, because there are so many non-medical needs, we do also use this quite a bit for non-medical things. We're not at this point able to bill for that, but I think sometimes just being able to have that face-to-face and go through things with a patient is more effective. And again, we're sort of lucky because we do have a team of not just providers, a doctor and a PA, but we also do have caseworkers and whatnot for support in our clinic as well.
Great.
And Doctor, can you just add to that the time it takes to do the phone call versus the virtual visit?
Yeah, exactly. So that's the other thing too, is I think, sometimes, again, because these questions are not just so straightforward when we're doing a telephone call, it's not a 5-minute call. It's usually like a 20-minute phone call. So again, that's a lot of doctor time to use without billing. So that's really helpful. And sometimes also just being able to see it, we can evaluate much quicker than the family kind of describing extensively what this rash is or what's happening with the G-tube. So again, saves us time too.
Got it. A question in terms of implementation, since there's no universally accepted standards for quality metrics, do you have any recommendations for creation of an evaluation framework or what to keep in mind when creating one?
Wow. So I don't know if I can answer that in 2 minutes.
Great question off the top of your head. But yeah, what are the things you're looking at in terms of that you all have thought in terms of, I know you thought about creating some evaluation tools. Are there particular outcomes you're interested in?
Yeah, absolutely. So we, and again, I think for us, again, because our focus is really on this specific population, we've really been trying to correlate some of the specific transition measures that are out there with telehealth. And I think, like, for us, a really big one is obviously adherence, right? So does this increase adherence? And then you kind of get into the specific conditions. So if it's diabetes, maybe looking at A1Cs. So some of the similar things that we actually do in just kind of regular clinical, correlating that with if we're using telehealth. So adherence is a big one. No-show rates is another huge one, because again, we know that this is a population that tends to have a really high no-show rate. So that's the other one. And then I think also really looking at this medically fragile population and looking at satisfaction and quality of life. Because again, coming into an office with almost an entire hospital room and then having to bounce all the way here, with all the bumps in the road, it is really, really kind of putting an unneeded stress on the family and the patient. So those are some of the things we thought about, but definitely a work in progress. We, not much in the literature that really.
Yeah. You have another question that's come in. Do you have a video of real life telehealth demo that you use in training? I think more on the physician side. And how long is the training program for clinicians? And then in terms of kind of setting up a telehealth visit, specifics, I know most of this sounds like it through Epic is the platform that you all are using.
So we do not have a video. We used to have a video, but unfortunately the process in the beginning changed very rapidly. It was so it was hard to keep up with those changes and updates to our process. So we don't have a video. We are in the process of creating one for training purposes, for not only the providers, but also our CSRs and our MAs. We're also working on some possible visual materials as well that they can keep at their desk. As far as the length of the training, it's not long. It's a PowerPoint presentation that we go through, and it's probably, I think it's about 40. I just went through it the other day. It's about 40 slides that we go through with them. It talks about insurance and what's covered, and it diagnosis that they can use it for. And after that, we do have a checklist that we go through with them to make sure that we've touched on every point and that they understand it. And then we do run through a test patient with them as well.
Right. I wanted to add, so I think one of the things with this is it's almost like where you learn it, but you kind of have to work out the kinks as you go along. So I think you kind of have to go into it with a little bit of an open mind that it's not going to be perfect the first time, right? There's going to be little things, and then be able to kind of work with whoever your trainer is on working out those kinks over time. So I think it does require a little bit of like open-mindedness, and we went through that, and again I think now we feel very proficient, but it took us probably 3 or 4 months to really get to that place. And then the other thing I wanted to mention was, while we do everything through Epic, there is also the potential of using VidYO and Zoom also now, right? So
so right now we have we use a different platform. It's built into Epic called VidYO, and UF is working on, now that we've gone to the Zoom platform, on integrating that into Epic. So that will give us some more variations of. So right now we can only have it's basically 1-to-1, so you can only have 2 people on the visit. When we move to Zoom, we'll be able to add a third and fourth party if need be, which will definitely be a benefit and improvement to the process and the platform.
One of the questions that's come up kind of as it relates to that is just in terms of medical information security, safeguards, other HIPAA compliance questions or issues that you've kind of come across as it relates to these telehealth visits.
Well, everything has been vetted through the UF security department, so we're, we've fully HIPAA compliant and with our platform.
Got it. And I know with patient 5, you all mentioned kind of the super utilizer of telehealth. Have you found, I know one of your, as part of the protocol was to have 1 visit a year. Have you struggled with some of these patients who really, it's such a difference for them getting them back to the clinic once a year? Is that been a challenge or something you've been able to convince people to do?
So that is absolutely something that has come up. And again, I think really in particular for that medically fragile patient, and I always joke around that I'm not sure we're ever going to physically see them again. And I think part of that is really being very upfront with the families at the beginning. So we always say, like, this is an adjunct. It is still very important for us to do an in-person exam and discussion so that we can make sure that there's no issues, and oftentimes we will do a telehealth visit and it may be something where we just don't feel comfortable assessing, and we'll say I really think that you do need to come in for this. So that challenge exists, and I think it's really the communication and letting the families know. And again, if we haven't physically seen a patient in over a year, then we have to let them know we can't continue to provide, prescriptions and whatnot. And so we'll usually bring them in because they need something.
I was going to say too as well that there are some care coordination pieces that they have to sign off on that it just would not allow them just not to come in. So they will have to like lay their eyes on them and see them. So
excellent. Well, the last piece I'll address that came up was in terms of getting a copy of this presentation and slides, and we will definitely be posting this on our Free Center website and as well as the Primary Care Innovations CME website for if others want to access it. Want to thank our presenters today. It was really a wonderful, lively, engaged conversation. I think a hot topic that many of us are trying to figure out how to get going, and you all are off and running with it. So we appreciate you all passing on some of that wisdom to all of us. And for those that joined for the participated today, you will be sent a link to evaluate the presentation in order to receive CME credit. So please provide some feedback to our presenters so that you can get the CME credit as well. And thanks to all for joining.
Thank you
Thank
so
you.
much.
Bye.